Hi, I'm Punar. Over 9 million cancer patients face challenges like food insecurity and housing instability and financial burden, and that's directly impacting their health outcomes and healthcare costs. And today, cancer patients are given big resource lists and flyers through their oncologists and social workers, but this is very overwhelming. And what happens is that they end up in dead ends usually because by the time the services are needed, that they find out that they're no longer available. Our social referral platform, Connectedness, is the connective tissue between patients, community organizations, and providers. For patients, EmpowerNest is a mobile app that allows the patient to self-assess their social risk factors and self-refer to organizations and services. For community organizations, Community Nest is the portal where they can list their resources and services in real time and update them in real time, allowing us to match the patients. And EngageNest is a HIPAA-protected electronic health record interface for the clinical teams, through which the clinical teams can also refer patients to services. None of the existing technologies right now have this multi-phased architecture design. Our ideal customers are oncology practices that are engaged in value-based contracts because they have to address the social risk factors of their patient populations to improve patient outcomes and reduce costs. And some capitated payers have very similar incentives. And we estimate that a $25 per person per month pricing would be supported with a 3-to-1 return on investment. And now is the time with various federal initiatives and new payment models that actually integrate community support into payment policies. We've developed our technology largely through SBIR funding through National Cancer Institute. We were the team that won the Minnesota Cup's Impact Ventures this year, and we recently finalized and completing our pilot study with these amazing community organizations in our local Twin Cities that are focused on cancer. And to date, we've been awarded over $1 million in non-dilutive funding. And we have decades of experience within our team in economics, health economics, business, IT, cancer disparities, and community engagements to tackle this problem. Thank you.
Thank you, Pinar. That was a nice job. When you think, I mean, a lot of us have probably a number of health apps that are on our phone, and probably a number of them that are unused, right, over time. And so when you think about patients, using this and not just trying it out, but actually adopting it over time, what are the incentives or the reasons why you think that they're going to adopt this and then use it so that they get the benefit of all the whole network?
Yeah. I mean, the SBIR funding was very, very great. That allowed us to develop this technology in the platform with lots of focus groups and key informant interviews with the patients and caregivers. So we actually addressed a lot of their problems as we developed it. And one of the things is what patients really face problems is that when they receive these lists or binders, they basically now say, we don't want any more binders. That's what we heard over and over again. So what we are doing is we're really automating this service for them. And cancer survivorship is such a long journey. One other thing that we heard a lot from the patients is that their social needs are changing over the course of their journey. And that's one of the reasons why we wanted to have this patient activation and with very active community-based organizations. Like they say that today their needs is about house cleaning, but then they lose their job, they need legal care, or they have these more expensive drugs and they need help finding drugs. So that's what we are basically enabling the patients to use.
And have you done any tests or pilots or market research that looks at the long-term adoption of it or over a longer period of time?
Not long-term adoption. Our current pilot was a 3-month pilot, and we are just right now with that pilot. What was really interesting is we partner with the Minnesota Cancer Alliance, which is an organization that is a collection of community-based organizations focused on cancer. And with that, we recruited patients through the clients of these community-based organizations, so they're cancer survivors, and we measured metrics around engagement and ability for the technology to understand the social needs, the type of social needs, and our ability to influence the referral volumes. So we're at that, but the next stage is going to be exactly the kind of funding we need to be able to do this pilot in a longer term, in a randomized study design, and looking at longer term health outcomes.
Hi, Pinar. I love this this pitch and innovation because it it's a way to make things work better. I really appreciate that. So I wanted to ask about different customers, not the patient, but everyone on the healthcare side. And thinking about how I work for Boston Scientific, how enterprise-wide software is rolled out across our company, different divisions want to customize everything, and it makes things very hard. How do you anticipate those kinds of requests, people wanting different things, because that's not the way it's laid out, is not the way our department does stuff. And if you do go down the customization route, how are you going to manage that across different organizations?
No, that's a great question. The technology, there is no magic to technology in terms of scalability because it's designed with that flexibility in mind. Right now, for example, we are in our pilot, we are using the accountable health communities screening model, but there's nothing that stops us from adding different surveys, electronic health, electronic patient-reported outcomes, e-pros, as different organizations may be interested in. So it's very customizable. And in our currently we're writing our STTR phase 2 grant, and through that, one of the goals is to some of the technical developments we want to do is to actually improve our APIs and white label the technology as well.
I'm interested in the CBO side of things, the community nest side of things. You are so lucky to have so many resources here. You know, I saw Gilda's Club up there. I saw so many community-based organizations that can support patients here. How does the back end of the software actually help select? Because I could imagine that there's some conflicts between these different organizations that could offer some of the same services, you know, so I was thinking about that. And then the other thought was, we're so lucky here in the Twin Cities, there's the other side of the picture where there's care deserts, you know, where perhaps there's not as much community support. So if you could just tell me a little bit about resolving those conflicts and actually filling those gaps.
Yeah, so actually, first question about these community organizations, yeah, they're fantastic and we're so lucky to have them. And they are such amazing partners in the pilot, and they have all signed support letters to be for our phase 2 application that we are submitting. Actually, on the contrary to what you are thinking maybe, is what we heard from them in phase 1 is that they want to create a community within themselves. So they're very excited about our technology because our technology allows them to refer to each other. We've designed that future because that's what we heard from them. And so Gilda's Club says, you know, we're great in terms of some of the support services that we do, but we want to be able to refer to Open Arms for some of the food insecurity, or we want to refer to the cancer legal care if the patient. And so they are actually not that, we have not had that, we have not heard it from them that they're competing in their services, but rather that they want to refer to each other for the complementary. And I think it relates to the other idea that the cancer journey and survivorship requires so many different kinds of supports throughout. The second question. Yeah, so one of the wonders of COVID is that it actually created a lot of virtual care. So something that in between our phase 1, what we were developing during COVID and now, is that we had to basically advance the technology a little bit more to address that their programs when we're matching with the patients, that you know they actually deliver a lot of care at a state level and a nation level.
Thank you.
Thanks.